Thank you for the Egyptian Society for inviting us. I'll talk about anti-herpetic uveitis. I have no conflict of interest. In the uveitis clinic, uveitis specialists may face a lot of phenotypes of granulomatous anterior uveitis with primary high and it's of multiple etiologies. Commonly, it will be caused by viruses, and herpes family is one of the main causes of those entities. Usually, after the primary infection, it persists in the latent form, and then it might be reactivated and causes keratitis, anterior uveitis, or retinitis. Herpetic anterior uveitis is a major cause of infectious anterior uveitis in developed and developing countries, accounts for 5 to 10 cases of all uveitis. It's mainly diagnosed by its characteristic finding and improved by molecular techniques. The clues for the herpetic viral uveitis: unilaterality, hypertensive on onset, the iris changes, and mostly it is granulomatous with corneal and skin lesion plus minus. So those are the main 3 phenotypes, and from each we can have several phenotypes. The first one is with multiple large KPs with plus minus keratitis, definitely with iris changes, and it plus minus skin, and it is predominant in herpes simplex and PZV. CMV had 2 forms. One of them is the acute form with Bosner-Skozman-like syndrome with spikes of high IOP. The other one, which is described a bit recently, is the fox-like uveitis, and mostly it is usually it is a chronic CMV. In herpes simplex, the uveitis is usually unilateral with raised IOP in most of the cases, granulomatous KPs. Mostly it is associated with keratouveitis in multiple forms, epithelial, stromal, endothelial. The iris changes in acute stage is a bit different from the chronic stage, and you may notice first there's iris atrophy, but usually you will notice the flattening of the iris and iridoplasia localized before the appearance of the iris atrophy. Later, the iris atrophy of dominant form. Some classification criteria for herpes simplex uveitis, depending on clinical feature. You can do the PCR, but it is not a must. The iris changes in a patient of less than 30 years, and the keratitis is suggestive in the absence of concomitant dermal cutaneous varicella zoster changes, and with the exclusion of other causes of hypertensive uveitis, mostly syphilis. PCV is common more in older age group and in immune deficiency. It is somewhat similar to herpes simplex virus, and it is ocular finding with concurrent skin lesion with the uveitis, or the skin lesion might happen before the uveitis, or in rare cases with no skin lesion. Again, the study criteria for varicella zoster depending on the clinical picture, with the evidence in older age of iris atrophy in older age and concurrent or recent dermatomal herpes zoster, and the absence of other causes, exclusion of other causes for the uveitis. The Titan Report 1 studied the global current practice of pattern for the management of herpes simplex and zoster, but mainly with this consistent, there was known that the clinical sign again is sufficient for the suggestion of herpetic uveitis. And they defined some point in the treatment, and one of the important one is that resolution of inflammation with the normalization of IOP considered to be the end clinical point for treatment. And this is the algorithm for treatment, and it is mainly depending on the valcyclovir as the main route as the main treatment modality for the herpes simplex zoster and PCV, but with more dosage of the treatment for the PCV, and it is accompanied by topical steroids and topical antiviral in case of epithelial changes of the cornea. Now coming to the CMV anterior uveitis, which accounts for 25% of hypertensive anterior uveitis. It had two forms, acute relapsing, one with high IOP, and the iris atrophy in this form is usually absent. And then the chronic type, which look like Fuchs with iris changes. So the Bosner-Skolzman one is the classically come with sudden onset of headache and blurred vision, minimal injection, spikes of high IOP, and few gray, white, medium granular KBs. Actually, the KBs in this is a point I want to illustrate, that the KBs in the Bosner-Skolzman syndrome is different. It can happen in definite form. The most important issue, but is that there is no iris atrophies, no posterior. And this is another demonstration of the KPs in the acute form of CMV. The chronic form, the KPs is somewhat similar to Fuchs. This is not the KPs of the chronic. This is the acute one, unfortunately. This is missed here. With the diffuse KPs and the iris changes, no or almost no vitreous inflammation, and CME absent. The classification for the SANIC criteria classification for CMV anterior uveitis was not based on clinical finding, which I am illustrated now. It is mainly on the PCR. So it is definitive diagnosis. They insist in the SANIC group to have definitive diagnosis. But nevertheless, now a lot of uveitis expert is issuing a lot of articles of how to title the criteria for presumed anterior CMV uveitis and to treat it, and there is a lot of publication and literature about this issue. This table is nice to illustrate some of the differences that we talk about. The age is mostly of younger in the herpes simplex, high in PCV, and then chronic CMV. The posterior synechiae is absent in both CMV chronic and acute. Iris atrophy is diffuse or patchy in CMV. IOP is almost always elevated in CMV. And vitreous changes is almost minimal or zero in CMV. And the recurrence is high in CMV compared, especially the Bosners, compared to others. The Titan report manifested, illustrated the global current practice in the pattern for the management of CMV. There is a lot to talk about this, but we will talk about 2 points that most of the experts prefer even if it is presumed, you can use the gel or the oral use of valganciclovir is mandated in cases of recurrence and persistent high IOP and several attacks of more than 2 in 1 year, especially if there is no systemic contraindication. And again, unfortunately, in case of CMV, it is not of short of short duration for the antiviral. We can discuss this issue later if there is time. So again, this is the first illustration that I put it, and we can guess here from the clinical characteristic what type of uveitis is this. And please, in all cases of anterior herpetic uveitis, don't forget to examine the fundus, rule out retinitis, toxo, and of course, don't forget masquerade. So the take-home message in this issue is that for simplex and PCV, the diagnosis is mainly clinical. IOP is a signal, but not a criteria. A treatment mainly with systemic valcyclovir, besides topical acyclovir and topical steroid. For CMV, it had many forms, mainly with IOP spike. There is no CMV with no IOP, not like mFOX. CMV diagnosis could be presumed if you don't have the PCR or the PCR failed to prove it, but it should be proven if you are following the SUN criteria. And the ganciclovir, topical, systemic are showing good therapeutic outcome in such cases to avoid any glaucoma surgery in such cases. Thank you very much.